Capnography. All right. To me, capnography is like a sort of encrypted, weird thing. You know, it's like candlestick graphs for share prices. I could never understand it. But it's quite simple and you can use it to your advantage. And with my registrar, sometimes I'll have a look at a capnograph tracing and I'll say, wow, this patient's liver function test might be a little bit off based on that trace. And they'll look at me very strangely. And I'll just walk away like it's normal. Of course, you can't tell what the LFTs are, but you've seen them beforehand. They look it up and they go, wow, he's right. And you just never tell them the truth. Okay, you just keep going. So let's have a look at a few traces based on some case studies in capnography. So when we look at the capnograph, we've got particular stages. You've got the beginning of expiration. You get rid of all the whatever you've got in your dead space. Then you get an increase in your CO2 as it comes out. Then you get that plateau phase up the top. And the plateau phase is this constant phase where the CO2 comes out, and the end-tidal CO2 is measured where that circular dotted line is. At the end of end-tidal CO2. What happens then is you start to go down the inspiration, and so the end-tidal CO2 drops significantly. And that's the sort of waveform we want to be looking at. We want to maintain the alveolar plateau because there's a constant amount of CO2 coming out. We're going to have a rise, constant, and down. Now, what determines the height? Cardiac output determines the height. This is all about ventilation, oxygenation. Ventilation, the number of breaths we take, and oxygenation. The end-tidal CO2 reflects or is a surrogate marker for cardiac output, and we'll use it in resuscitation. We'll look at a case in a second. So let's just have a quick look at a few cases of how we might decide. And there's 4 or 5 easy capnographic waveforms we want to look at. So this is a 25-year-old who comes with an overdose, GCS is 7 on 15. He's taken something. I don't know what he's taken. GCS is 7 on 15. What's a better marker? Gag reflex or Glasgow coma? Of course, Glasgow coma. Let's stop shoving things down people's throats to test for a gag reflex. So anything less than a 9 is a coma. Let's intubate. So we decide to intubate. So the registrar decides to intubate. The patient is pre-oxygenated because, of course, they get apneic oxygenation the second they come into my emergency department. And the senior registrar performs RSI with propofol and rocuronium. So he's asked to leave the room because he hasn't used ketamine in my emergency department. All right, I'm very angry at this guy. So endotracheal tube is passed. Registrar seems pretty good. So I see the tube misting. I'm a happy camper. Chest wall movements are appropriate. End-tidal trace is attached, and we get this. Looking good. All right, so what's happening here? So this is the classic trace of an esophageal intubation. So you're getting some end-tidal CO2 being produced for the first 2 or 3 waveforms, and then it dies off. Could it be obstruction? Yes, it could be. But in the setting of an intubation, it's got to be an esophageal intubation. And that's why we insist usually on a minimum of 6 waveforms, 6 end-tidal CO2 waveforms before we diagnose that the tube is in. Okay, 6 waveforms, let's do that. But hang on a minute, wasn't there misting of the tube? Wasn't there chest rise? Didn't somebody listen, do a 3-point check and say, sure, I can hear that? Yeah, but let's have a look at what it says, what the literature says. Misting occurs in 80% of esophageal intubations. We don't trust misting of the tube. I saw it go through the cords. No. End-tidal CO2 is what we trust. Good 6 solid waveforms is what we trust. Transmitted breath sounds occur, and I've actually heard transmitted breath sounds that sound just like it might be in the lungs, and you're fooled. What's the end-tidal CO2 show? That's the question we need to ask. Chest wall rises in about 15% of patients, as you'd normally expect it to. You're looking at the chest wall, you've intubated, it rises, it's esophageal. So we don't trust those, we trust end-tidal CO2. So we pull the tube out, and I've done this before. You know, I've tubed the patient. I remember as a registrar tubing the patient, and I said, right, I saw it go through the cords, it's misting, I can see the chest rise, it's in, SATs aren't going up, I'm not getting an end-tidal CO2, I've seen it go through the cords, SATs aren't going up, I'm not getting an end-tidal CO2, you know, it's misting. And then you say, you're an idiot, take it out, it isn't in, right? So you take it out, we re-intubate this person. Appears successful. Endotracheal tube is 24, 25 centimetres at the lip. End tidal CO2 is attached. Good air entry bilaterally. The registrar listens and says, fantastic air entry bilaterally. Great. Great. So then we get the end tidal CO2 trace, and it does this. Did that registrar that listened to those lungs lie? Yes, they lied. Because this is a double waveform, and you see this double waveform occurring because this tube is down the right main bronchus. So you get the end tidal CO2 coming up first, and then you get a second waveform overlapping it as the end tidal CO2 comes out of the left lung. Because you do